how delighted I am to be sharing this talk with you. It's been a while والحنين للبلد والوطن والرغبة في to push forward the wheel of education in Sudan is the thing that we've been deprived of by this war. لكن القناعة إنه we're coming back إن شاء الله stronger and better nation. Without further ado, let me get into the presentation. It's about DAPT duration in ACS PCI. Actually, it's in every PCI that you need to tailor your DAPT because as the idiom in English language says between a rock and a hard place, but we just change that to a hard place, being the talk about the heart. It's a well-known title for many talks in international cardiology meeting. It's between preventing thrombus of the stent, which can lead to death, and avoiding bleeding. So between a rock and a hard place, between المطرقة والسندان, انت بين preventing stent thrombosis and preventing bleeding because they are two ends of a spectrum. I want to take you back to the basic. This talk will be to all comers. Some people might find this very boring because it's basic, but I would really like to get everybody at the same wavelengths. So let's start by the basics of the pathology in atherosclerosis. Basically, the myocardium itself is an innocent bystander in all this. The problem, atherosclerosis is the disease of the artery. Many risk factors collaborate to pave the way for the process of atherosclerosis. Many risk factors. Let us take the lipid depicted here in the yellow sphere. When there is excessive lipids, it accumulates in the artery wall. It gets oxidized and turn into the brown color. When there is persistence in its existence, it sets an inflammatory response that the intima will express adhesion molecules for the inflammatory cell. The leukocyte uses these adhesion molecules to get from the bloodstream into the intima. Once they are into the intima, they turn into macrophages and they start to pick up these oxidized lipids, turning into foam cells. Foam cell is the hallmark of the fatty streak, the early process in atherosclerosis. Lesion complication begins when the smooth muscle in the intima begins to divide and excrete extracellular matrix molecule like collagen. Other cells will join from the media to strengthen the fibrous cap. The thicker the fibrous cap, the more strong the fibrous cap is. When there is persistence in risk factor like continuously high LDL, the lipid core grows and it sets an inflammatory response. White cells like T lymphocytes stimulate macrophages either by soluble signal or by direct contact. Stimulated macrophages start to secrete multiple mediators which break down proteins in the fibrous cap and make it susceptible to rupture. When it ruptures, it sets a thrombus formation. When it is sustained and occlusive, this is what we see in the ECG with ST elevation. But now we know that many of these plaque rupture are silent or not occlusive or transient. leading to partial occlusion of the coronary artery, and this is what we know as NST elevation MI with ST depression in the ECG. When this clot resolves, it sets a healing process which narrows the lumen and give you what we call a stable symptomatic coronary artery disease. When we intervene to lower the risk factor, this gives a chance for the lipid to depart and for the inflammatory cell to die by apoptosis, give you an uncompromised lumen and asymptomatic stable patient. Now, why did I mention this at the beginning? Now you heard two things, most important words I said in this process of atherosclerosis is inflammatory process. I used that twice, and the word thrombus formation. This is why in acute coronary syndrome there is this thrombus. نحن we call it في السودان خموج. بتكون الحتة خموج الارتري وبيكون there is a lot of inflammatory stuff going. But the fact that this complete occlusion of a coronary artery, we see it in as an ST elevation. The one that described this is Dr. D. Wood in this paper in 1980. He is the first one to say that ST elevation in the ECG is synonymous with complete occlusion of a coronary artery. So make no mistake, whenever you see ST segment elevation in the ECG, make sure that this patient artery is occluded. And we all know it. Nobody would miss that diagnosis. Now, how to treat this? So many trials tried different, because thrombosis is the initial process, as you heard. So thrombolysis is the logical treatment. Try different thrombolytic agent. The best they can get is can you see the marker on the screen?
Yes, clear.
Yeah, so many of them, the best mortality rate was reduced to 6%. But the next best thing is primary PCI. It reduced the mortality to 4%. So it's better treatment, stenting is better treatment for acute myocardial infarction. And this made the basis for this talk. ST elevation, non-ST elevation. Almost one clinical process, but different outcomes. And time is essence. This is a time-sensitive emergency. Not all the non-ST elevation are not occlusive in the ECG. And this is research we published from a SHAP hospital not long ago, 2023. We looked at all comers with non-ST segment elevation. No ST elevation in the ECG, and 20% with ST depression, they turn out to be completely occlusive coronary artery. And this is in line with the internationally published data. A stent, if you look up a stent, is now only recently got into the dictionary. A stent actually is the name of this dentist, Charles Thomas Stent. He is a dentist in England. He invented this compound. They used it to make the يعني بيعملوا القالب بتاع الدنشرز بتاع السنون. You put this compound into somebody's mouth to get a map of the size of the denture. This invention made him a very famous, and he was called by the Queen of England at that time, and he became the royal family dentist. And then it found its way to stent initially in urology for ureteric stent, and then came to cardiology. So the name of stent, the most likely historical background is coming from the من جد الزول ده جده اسمه ستنت وبالتالي حتى اليوم عشان كده لما تكتب ستنتنج طوالي يديك spelling mistake لأنه it's not a word, it's a name of somebody. Now we implanted the first stent. These are the two guys who implanted the first stent. This paper is 1987. They are both from Switzerland. One is French speaking and the other is German speaking. How did stent help us? Initially, we used only balloon. But with balloon, when you dilate an artery, the first problem, before even you leave the cath lab, is the elastic recoil. You lose 30% of the lumen gain by the time you deflate the balloon. Within 6 months, this is called the elastic recoil. Within 6 months, there is a remodeling of the stent, further narrowing of the balloon, chronic remodeling, you lose another 50%. So the ballooning only was not good enough. And then because you inflate the balloon so much, you get what we call new intimal hyperplasia. These are the three causes of lumen loss. The first one is elastic recoil within 6 months, chronic remodeling, and the third one is new intimal hyperplasia. With the stent, we managed to get rid of two of them. We managed to get rid of the elastic recoil and we managed to get rid of chronic remodeling. But the problem of new intimal hyperplasia remained a very daunting task at that time. 40%, 20% to 40% of stent have in-stent restenosis due to new intimal hyperplasia. And this nearly between surgery and stenting, patients at that time in the 80s and early 90s, they did not want to come back for another procedure because of the in-stent restenosis. This is why cardiology versus surgery cardiology was beaten fairly and squarely because of the problem of in-stent restenosis. What did they come up with? They come up with the drug-eluting stent using this magic medication which lead to cytostatic, not cytotoxic. It does not kill the cell, but it slows down this reaction. I was there, and many of الكوامر المعانا هسه في السودان were there when Mary Claude presented the Raville trial in Paris in around 2002 or 2003. She presented the first trial. It's called the Raville trial of the drug-eluting stent. Everybody she got a standing ovation for more than 10 minutes, which was never happened in a scientific academic presentation, because the incidence of in-stent restenosis was cut down to 0%, from 20 to 40% to 0% with the drug-eluting stent. So this was the revival of cardiology intervention in that era. That was a victory held by the cardiologist, and it opened doors for this. So drug-eluting stent was a landmark in the field of intervention. You know, when we do a stenting, we inflate the balloon to 16 atmosphere, 18 atmosphere, and if you عضيت جلابيتك ممكن تصل 20 atmosphere. The car tire is inflated to 4 atmosphere. So the pressure we put in this coronary artery is 4 times the pressure in the car tire. This tells you how robust this coronary artery are. But when doing that, if you look at the artery, we make a lot of cracks. These cracks are very thrombogenic. So now you have ACS with a lot of thrombus, al-Khamoja al-Guttu, and now you're coming to put a stent that you inflate to 16 atmosphere, causing these cracks. So two things together, the thrombus from the ruptured plaque and the thrombus and the thrombogenic atmosphere you're creating by inflating the stent this far. So we're facing thrombus big time. How do we deal with that? They came up with DAPT, the dual antiplatelet treatment. What were they doing before that? They were using warfarin. You put a stent and you give patients warfarin. You cannot give them heparin. Even Clexane was not invented at that time. So they were only relying on warfarin, and this is causing an awful lot of bleeding. The first trial to get rid of warfarin was a fantastic trial in 1998. They tried ticlupidine versus aspirin, ticlupidine plus aspirin versus the conventional warfarin, and the result was amazing. But ticlupidine, as you may know, has a lot of issues with the bone marrow, with pancytopenia and that stuff, so it did not last long enough. Then they come up with the classic trial with clopidogrel plus aspirin versus ticlupidine plus aspirin. They wanted to get rid of ticlupidine, and lo and behold, clopidogrel did a fantastic job, and they got rid of ticlupidine and the problem it causes in the bone marrow. So this is the start of the DAPT after stenting, clopidogrel plus aspirin. Then we moved on to FSCAI cure, clopidogrel plus aspirin versus aspirin alone. And again, if you can see on the right-hand side that the DES-MI and target vessel revascularization at 30 days are much better with clopidogrel plus aspirin. Then we had Triton, prasugrel, very strong antiplatelet versus clopidogrel. Bleeding was the same, but DES-MI, stent thrombosis, stroke were much better with prasugrel. As you can see on this prasugrel, the endpoints are less than clopidogrel. This is a strong antiplatelet. It showed, although there is the end result of the efficacy endpoints of causing harm with major bleeding, overall is okay, but they noticed there is a lot of bleeding. Clopidogrel is better than prasugrel when there is bleeding. And they eventually figured out these three groups of patients who are more prone to bleeding from prasugrel: the elderly patient weighing less than 60 kg, and patient with previous stroke. So this is why prasugrel is contraindicated in the elderly patient, in patient less than 60 kg, and patient with any whiff of previous history of CVA. And just by my experience here in the last 2.5 years, we're not using prasugrel routinely. It's mainly ticagrelor, which came in with Plato in 2009. In the Plato trial, ticagrelor versus clopidogrel is stronger than clopidogrel and is proven is better than clopidogrel in the setting of acute MI, and acute coronary syndrome. We then moved on to 2013, the Champion Phoenix trial, Kekagrelor, the first ever. It's not the first ever, it's the only IV injectable antiplatelet. It can bail you out when you got into trouble with the stent thrombosis while you're doing it. The beauty of it, you can switch it off and the effect is immediately gone. Again, it is not used routinely. This is the journey of dual antiplatelet. They help a great deal. So with that, we have a drug-eluting stent and we have a very good DAPT dual antiplatelet, and we were flying. Everybody was happy till 2006 in Barcelona, this World Cardiology Conference. It was Sunday. Half of the conference are gone home, and this gentleman, Eduardo Comedent, from University Hospital Geneva, presented his talk. That was the landmark talk. He presented a data comparing drug-eluting stent to bare metal stent. And he showed clearly significant mortality with drug-eluting stent compared to bare metal stent. With the Taxus, many of you might not be there at the days of the paclitaxel drug-eluting stent, and Cypher is sirolimus eluting stent. Both showed 38% increase in mortality and 16% in Cypher, 38% in Taxus. That presentation was very devastating because he himself, he said, from now on, doctors, cardiologists should not be using drug-eluting stent. And Yusuf Salim commented on that, calling for cessation of drug-eluting stent implantation. And this went viral, was trending in the media. Now, the social media at that time in 2006 was not X or Twitter, was not WhatsApp. It was tabloid newspaper. And look what happened. They picked up on this. He said until several second generation drug-eluting stents are available, interventional cardiologists should avoid the indiscriminate use of drug-eluting stents. Coupled with Dr. Yusuf Salim, which is a well-known figure, calling for cessation of drug-eluting stents. Now you could imagine the disappointment in the cardiology community at that time. And this was picked up by this New York Times, newer stent pose dangers, the two doctors say, because this was Komamenzet and Salim Yusuf. Cardiologists question, I see let me move the cursor, questioning the safety of using drug-coated stent. A heart stent gets reprieve from doctors. Risk of drug-coated stents divide Federal Review Board. These are what the headlines in the newspaper in 2006 in September, after these two doctors commented, nearly killed the field of interventional cardiology. And this led to, look, this was the drug-eluting stent used in the United States at that time before the meeting. Come the meeting, precipitously dropped. A steep drop in the use of drug-eluting stent after this meeting in September 2006. كجلمود صخر حطه السيل من علي. everybody is abandoning the drug-eluting stent, setting us to square one, back to the Stone Age. It's just because of the comment of these trials. He was right, so, but eventually it turned out that there was a data misinterpretation of data. But anyway, the damage was already done by this meeting that led to the FDA, the Circulatory System Medical Device Advisory Panel. They met twice in 2 days, 7 and 8 of December 2006, and they said it's okay to use drug-eluting stent, but you have to use DAPT for 1 whole year at least. Do you understand where the 1 year DAPT came from? And we're still using it, although the evidence are coming thick and fast to shorten DAPT. This all is from another paper from a guy from Ireland that he published in 2004. Nobody paid attention to it. He said concern has arisen about the potential of late stent thrombosis related to delayed industrialization of the stent. He reported 4 deaths from using drug-eluting stent. So to recap, drug-eluting stent were good. We managed to get rid of in-stent stenosis. We managed to get better than surgery for elective and for treatment of for primary PCI till 2006, when this report came out and everybody was looking back to correct it. They said the first generation of drug-eluting stent was not good enough. Why it was not good enough? Because it is causing stent thrombosis. Stent thrombosis could be acute within the first 30 days. This is the best paper at that time to describe this, published after this in 2007, describing the incidence of stent thrombosis. If you noticed, most of the stent thrombosis occurring in the first 30 days. If you can keep the artery clean in the first 30 days, the rate continues at the same rate, which is 0.06%. But more than 50% of the stent thrombosis occurs in the first 9 days. The median is 4 days. And this is because of what we do with the stent, inflating it to that much. And for the thrombus, if you're dealing with acute coronary syndrome. But after 30 days, the rate is steady for 3 years. So stent thrombosis is real. This is why we need to prevent stent thrombosis by DAPT. But if we continue to cater for all this period, we increase the risk of bleeding, as I'm going to show you now. So this called for the engineers, the medical bioengineering, the interventionist scientists to come up with new stent. Look how we were making stent. This is called a slotted tube. The first stent was made, 1 tube. You can imagine it will be a very, not that flexible, but it was very good. The stent struts are thick. We moved from this technology to another technology, 1 wire, sinusoid technology. 1 wire, you wrap it around, you wrap it again, and laser fused it with Telhamel laser. very flexible stent. It's not only that, when you crimp it, the struts are very thin. This is how the stent is made. You get the balloon in the middle and you crimp the stent over the balloon to make it, the crossing profile is very small. So in this technology, the strut thickness was 140 to 160 micrometer in the first generation. They managed to reduce that to 74, and now we have the Orsirio 60 micrometer thick. The blue stuff on this side, you see the lumen in this side. In this side is the wall of the artery. This is why it's called abdominal. The blue thing is you cannot put the drug directly in the metal. You need something to hold the drug. It's called the polymer. So the polymer also was found to be a cause of stent thrombosis. So they got rid of the polymer, or they come up with a biodegradable polymer. After 3 months, this polymer is gone, and the stent, after doing the drug elution and the cytostatic function, it becomes a bare metal stent again. So there is either durable polymer or biodegradable polymer. So this polymer is very thin now. It's 4 micrometer, and it's only in abdominal side, only where you need it. There is no point in having on this side polymer. Very thin, and is biodegradable polymer. So these are the changes they came up with to cater for the incidence of stent thrombosis. They come up with the sinusoid technology in making the stent from one wire. They got rid of the polymer, and most importantly, they lower the thickness of the stent. I will show you why do you need a very thin strut. And this guy was saying industrialization. If you look at this, this is a small thin strut, and this is a thicker strut. If you want industrialization in a thick strut, it has to travel all this way. Look at this, how industrialization. Within 30 days, if you have a thin strut, within 30 days, you will have complete industrialization and the stent will be buried. 30 days, and as you notice, 60% of stent thrombosis occur in the first 30 days, 50% in the first 9 days, and most of it is in the first 4 days. So if you have a thin strut, this allows the industrialization to be complete and to the stent to be buried. No any stent exposed to the lumen. So this is how intelligent these people were, and they did that in a very short period of time. They come up with these technologies to cater for this. Now, this is how you put it. It's not only the thin strut, but you have to make sure you adhere this stent very closely, no gaps to the wall. This is called a position. A position is an independent risk factor for stent thrombosis. If you leave gaps like this, you're asking industrialization to jump. These gaps, it's easy for industrialization to be complete here and not here. Angiography is not good enough to show you this. This is why imaging came in. Look at this guy, Antonio Colombo, the father of intervention in 1995. 1995, he was using IVUS to optimize the stent to avoid using warfarin. And he did that. He used inserted in coronary arteries, the Balmazans, that was the stent of the day, can be safely inserted in the coronary arteries without subsequent anticoagulation, provided that the stent expansion is adequate. So he confirmation of adequate stent expansion by IVUS provide assurance that anticoagulation therapy can safely be omitted. This is what he had in 1995. Look what we have now. We have OCT and very advanced IVUS as well. So this IVUS can show you these yellow dots correlates to this yellow line, correlates to this yellow line. This is AI in cardiology. Big time is coming. This is Altrion 2, and they're now building Altrion 3. You don't have to think. You don't have to see it. The software will tell you where is the malposition. This is called co-registration, so you know exactly when you are in the artery. And this is what we use now day in and day out. If there is any opposition more than 0.3 millimeter, you can set that up, you can make it 0.2 millimeter, but the standard is 0.3 millimeter. If there is any malopposition more than 0.3 millimeter, the software will tell you, and you need to go back and post-dilate. So this, when you eliminate this malopposition, good job. A cardiologist needs to do a good job. When you eliminate malopposition using a state-of-the-art stent, very sinister abdominal biodegradable polymer, 0.4 micrometer thick. If you are doing the procedure in a high-risk patient and you want to make sure, you want to shorten the DAPT and avoid the stent thrombosis, you have to do a good job and utilize this technology. So there's no excuse now in this part of the world if you're doing a procedure in a high-risk patient not to optimize the procedure with this. And you don't have to think, white dots, this is good opposition. Yellow dots, there is a gap here, doctor. You have to do something about it. So now we kind of overcome the problem of the first generation drug-eluting stent. We have very good antiplatelet, very strong prasugrel, ticagrelor, and we have the aspirin and clopidogrel. And the question, for how long shall we use it? After the American FDA said a minimum of 12 months, people started using it for 12 months. Some people even went further. And these are all the trials testing different duration. And of course, when you prolong DAPT, longer DAPT, more than 12 months, you're definitely going to lower the ischemic events. As I said, the stent thrombosis goes on and on and on at a steady rate at 0.06%. So if you continue with that, you're definitely going to reduce this 0.06, but you would have more bleeding. So it is not safe to continue that long. I'll tell you, out of this, I picked up on one trial. If you prolong DAPT, these people, including Salim Yusuf himself, they showed that if you prolong DAPT, no, they didn't show that. They showed that if you have bleeding, depending on the amount of bleeding, there is a direct link between bleeding and mortality. The higher the bleeding, the more mortality you get, depending on the degree of bleeding. This was the alarm in the Oasis trial. So they told the world bleeding is bad. We kind of know that, but you need such trials to confirm that for you. Now, I picked up this trial, DAPT study is called. The inclusion criteria, if you tolerate 12 months of DAPT, no problem, no stent thrombosis, no bleeding. After 12 months, then they randomize you. They randomize the patient either to continue on DAPT for more than 12 months, actually to 33 months, or aspirin alone. This is after 12 months. So people who continued on aspirin alone, this is the placebo group, they had more MACE, while the continuation with the double antiplatelet is much better for MACE, death, MI, and stroke. Stent thrombosis, better with dual antiplatelet. This is thiopridine, as I said. You continue to 33 months, you're going to see less stent thrombosis. But mortality and bleeding were going on the wrong direction. You cannot tell me this is statistical significance or not significant, is not power for that. No, when death is linked with bleeding, going on the wrong direction for this patient, like you showed me here, DAPT is better because your MACE is better. The green line is when the thiopridine, you're using both of them. And stent thrombosis is better. But you're coming and telling me people are dying more when you continue with the dual. On this side, thiopridine plus aspirin is better in stent thrombosis, in MACE, but when it comes to death, aspirin alone is better. So death and bleeding are going on the wrong direction for this population. So now we know extending DAPT more than 12 months is bad. Although it reduces stent thrombosis, but it is bad. For any stent thrombosis, one stent thrombosis you prevent by using DAPT more than a year, you increase the bleeding 2.1 fold. So this is how people realize it's not only stent thrombosis. If we're preventing stent thrombosis but killing patients with bleeding, and this is a rock and a hard place. And if you look at it, MI, the risk of MI and death, when it comes to MI, it dissipates as the time goes on. But the risk of bleeding, killing people, it persists. It lingers on and on and on. So that you have to pay attention to bleeding. Do not chase preventing stent thrombosis alone. You have to cater for this. Now, this is, after that trial, they start thinking of reducing DAPT. And this is the major 5 trials. 6 months versus 12 months of DAPT. The top thing, is MACE, no difference between 6 months DAPT and 12 months DAPT, no difference in MACE. Major bleeding, short-term DAPT prevailed to be better. So by reducing the 12 months to 6 months DAPT, you're winning because you're reducing bleeding. This is the 5 major randomized trial. So now the shift already began from using 12. The FDA asked for better stent, we gave them better stent. They won't budge from the 12 months. Now the trial are coming thick and fast to prove the point. So short-term DAPT reduce major bleeding events compared with long-term DAPT without increasing the incidence of ischemic events. If you notice in all these trials, they did not stop aspirin. They stopped the cyuberidine because aspirin was held as the savior for many, many years. But now when we have medication to lower the risk factor of patient, the question came up, is aspirin as important as it used to be? With all the problem of aspirin, even the gastroprotecting aspirin can cause bleeding in the duodenum, so shifting the bleeding from the stomach to the duodenum. Aspirin was bad. This is how they put it. Risk reduction, it has the same place as it used to be, because now we have lipid lowering agent with treating diabetes better, with treating hypertension better. We have novel antithrombotic medication. So aspirin was in question. Why are we insisting in using aspirin? Even when we stop DAPT, we continue with aspirin, and this gave us some stent thrombosis. Aspirin and B2Y12, they work almost the same. B2Y12 are proven stronger than aspirin. The Cabri trial, head-to-head comparison between aspirin and cyuberidine always triumphs. It's much better. But there is a caveat in that. Don't take it in a good face that cyuberidine are better than aspirin all the time, and I will show you why. You see, the activation of platelet with ADB, the cyuberidine are very good at it. Aspirin work differently. The stimulation for this is collagen. It prevents the acetylization of arachidonic acid. Cyuberidine cannot do that. Where does that come in our equation? I will tell you. It's always in the first 30 days. Most importantly, in the first week after a stent, after putting the stent. They tried 3 times. They managed to be successful only 1 time to eliminate aspirin. Aspirin during the first week and during the first months is of paramount importance. Whatever you do, do not touch aspirin in the first week to first months after putting a stent, and I will show you the evidence. Now, they all agreed that aspirin is not the hero as historically it was portrayed, and they tried in these mega trials since 2018. They tried this and successfully proven beyond any reasonable doubt. After 1 month or 3 months of DAPT, you can safely stop aspirin and continue with either ticagrelor or prasugrel, or clopidogrel for that matter. So these are all the trials that change the guidelines and they change the mindset of interventional cardiologists. The bigger the circle, the bigger the number of patients in the trial. You can see blue is where the trial, they all stopped aspirin. All this trial, they stopped aspirin either after 1 month or after 3 months and continue with the other medication, either ticagrelor or prasugrel or clopidogrel. The trials with the dotted line around it, these are the trials of ACS patients, all these dotted. So it's been tested, buried and dusted that it is safe to stop aspirin after a month or 3 months and to continue. Let us take example of this. These are the trial of ticagrelor. They stopped ticagrelor here after 1 month, in Twilight after 3 months, and the global leaders, they stopped aspirin. Look at MACE. There is no difference, no significant difference. Stent thrombosis, death, MI are the same. Look at net adverse clinical events. Favors the net clinical adverse clinical event favor short term, 3 months or 1 month. Look at bleeding. Bleeding is significantly, as it all cause mortality, favors short term DAPT. With all this medication, the evidence are coming thick and fast that you can safely stop aspirin after 3 months or 1 month with some risk of stent thrombosis numerically. I'll show you when it touches statistical significance. So no advantage for prolonging DAPT beyond 6 months. This is the conclusion from these trials. In reducing thrombotic risk with contemporary drug-eluting stent, you do not need to go beyond 6 months in any case to reduce thrombotic risk. And you gain a benefit of no bleeding. They went further than this. What you're looking at is the definition of a complex PCI. Complex PCI now is defined as if you stented 3 vessels, if you treated 3 lesions, if you put 3 stents, or the length of the stents is more than 60 millimeter, or you stented bifurcation lesion, if you intervene in left main or a CTO, or you use calcium modification, or you intervene in a graft. This is the definition of complex PCI. One of these things is a definition of a complex PCI. Complex PCI means the risk of stent thrombosis is high. So they got all these patients, very complex PCI, where they expect the stent thrombosis risk to be high, and they tested them. Half of them short DAPT and half of them traditional DAPT. So this is high-risk patient. It's likely going to have a stent thrombosis because you're putting 2 metal, there's calcium. This is the complex PCI, and they study it. Look at the result. In Twilight, after 3 months, ticagrelor monotherapy versus ticagrelor plus aspirin in a very complex situation, and ticagrelor monotherapy was the winner. Look at the bleeding. This is Bleeding Academic Research Consortium. I will show it to you in a minute. Bleeding is much better with ticagrelor alone. Look at this stroke, MI, probable or definite stent thrombosis is even better with ticagrelor. This is in this population of patients. So there is no fear anymore. If these patients can survive with 3 months short DAPT, nobody else will have any problem. So this is studied 50-50, and IntuAlight showed clearly that this is beneficial. So it's time, this is, but with this trial and another trial I'm going to show you in a minute, very similar, they forced change in the guidelines. Look at Master DAPT trial. Master DAPT trial have abbreviated DAPT and have standard DAPT, complex PCI. في صوت كده.
Yes, I mute all. Please unmute yourself, Dr. Awad. Dr. Awad, please unmute yourself. Dr. Awad, if you hear me, please unmute yourself. Dr. Awad, if you can hear me.
Yeah, can you hear me now?
Yes, yes, thank you very much. Please continue.
Okay. So we said they tried that in a high-risk patient. Again, they repeated the same in Master DAPT. Master DAPT, about half of them had acute coronary syndrome. 1/3 of them had warfarin or NUAC because they needed that. So what happened in the Master DAPT, as you can see here, complex PCI, there's no difference in ischemic event. There's no difference in major cardiac and cerebrovascular adverse event. There is no difference in net adverse clinical event. But look at bleeding. Bleeding is much better when you use abbreviated DAPT. On this side, to continue, DAPT is better. On this side of the slide, abbreviated DAPT is better. You can see this is bleeding is much better with abbreviated DAPT. These again are patients, we call them complex PCI. And complex PCI, you know, is not a joke. It's these people, bifurcation, double stenting strategy, long stent, 60 millimeter, 3 stent, 3 vessel, 3, a lot of metal. Left main, you do not want to play games with left main. Stent thrombosis, this is the highest complex PCI a cardiologist can do. When you need calcium modification and when you intervene in a graft, these patients, they will all brought in this study 50-50, abbreviated DAPT or continue DAPT. There's no difference in the net adverse event. There is no difference in major adverse cardiovascular thing, and there is much better bleeding profile. So these with these trials, they managed to pave the way. That was in 2019. You can ask me, نحن أولاد النهاردة. This trial, the target first trial, was published 3 months ago. 3 months ago, DAPT, short DAPT, and prolonged DAPT. 1 month. 1 month of aspirin plus either ticagrelor or prasugrel. Look at the estimated percentage of patient. This is bleeding. In blue, the short DAPT, single cypridine. Big difference in bleeding, much better. Look at stent thrombosis, this MI, no difference. This is published when? August 31st, 2025. أولاد عمها ما سمعوا بالترايل دي لسه. This is in 40 European countries. You understand? This is coming thick and fast, the evidence for shut up by evidence. Another trial, new mindset in Brazil, also published in the same edition of New England Journal of Medicine. These people went a little bit further. They stopped aspirin from the get-go. قالوا ما دارين أسبرين أصلا من البداية. شوف حصل لهم شنو؟ لقوا إن الستنت ثرومبوزيس is much less when you use DAPT. The red one is no aspirin. Compare DAPT to single cypridine. MACE is the same, okay, not statistically difference. Bleeding is less, although not statistically significant when you use no aspirin. Aspirin is always associated with bleeding. But look, لما تفتري على الأسبرين during the first week, stent thrombosis comes in again as the devil. So they get to know, although the evidence were there, do not touch aspirin during the first week or during the first month. All the trial I showed you, this one is 1 month dual antiplatelet. This one, 3 months of dual antiplatelet. Twilight, 3 months. Aspirin was used after the stent for 3 months, and some of them for 1 month, like the target first trial, August 2025, and new mindset. Only one trial tried, it hasn't finished yet. They published the 3 months follow-up data. It's called ACID, acetyl salicylic acid elimination trial. 0 aspirin. Half of the patient from Japan and half of the patient from Brazil. In Japan, 99.9% of patients, they used OCT imaging. They made sure إنه ما خلوا حاجة وراهم. يعني ديل جضموها للنهاية. ما أدوا الزول ولا أسبرين. من ما طلع من الكاس لاب نوت أسبريناية واحدة. يعني ده زيرو. في البرازيل, the usage of imaging was 19.8%, 16.8%. In Japan it's 99.8%. فده بيوريك أهمية إنك تجضم الشغلة. دي اسمها الأسيد ASET Acetyl Salicylic Elimination Trial. دي حتشوفوها اللي هي هي في جاك. دي الأسيد بايلوت. لوك هي كانوا بياخدوا دابت وكده وأي حاجة، لكن أول ما جاء زيرو دي هنا ده اوبتيمال PCI result، عملوا PCI، وقفوا الاسبرين طوالي. اسبرين discontinued. This is the first time ever يتجرؤوا على الاسبرين في ترايل زي دي. بعد 3 شهور بس هم ما صبروا عليها، لقوا انه stent thrombosis is zero no difference. فدي تديك اول جليمس انك you can get rid of aspirin، لكن باقي كل الترايل they failed. فnow you know you have to choose judiciously. You have to use judiciously is يعني judiciously to choose. Judiciously معناها to choose بحكمة. Who to prolong DAPT on and who not to prolong DAPT on. It's all about balance, individualization of the treatment. عشان كده قاموا تعرف، لازم انت تعرف عيانك ياتو الهاي بليدنج ريسك، وده المين pivotal point of my talk الليلة. If you're going to get out of anything, just get out with this one single information. Anytime you're taking a patient to a cath lab, before you take the patient to the cath lab, calculate the bleeding risk of this patient. Are you dealing with a high bleeding risk patient or not? ودي ما كنا بنعملها. From now on you have to do this. High bleeding risk. منو high bleeding risk? How do you calculate the bleeding risk? This was a dilemma. الجماعة دي عرفوها، قاموا تلموا كلهم 31 members. 2 meetings، واحد في واشنطن واحد في باريس. فيو أي زول you name it. فيو ال FDA، فيو ال Pharmaceutical and Medical Devices Agency بتاعت اليابان، فيه الAsian، فيه ESCC، AHA، American College of Cardiology، pharmaceutical, industry. Everybody was represented في this meeting. قالوا we cannot نخليها كده سايبة، وأي زول يعرف البليدنج ريسك شنو، what is bleeding ذاته. قاموا عملوا حاجة اسمها الأكاديميك ريسيرش كونسورتيوم High Bleeding Risk Consensus. You have to know this by heart. It's an app. تمشي جوجل ستور ولا أبل ستور، تنزل ARC High Bleeding Risk Criteria، وقسموا الكرايتيريا دي. عندك major criteria و minor criteria. If your patient is a high bleeding risk, you cannot continue with DAPT for 12 months because you're definitely going to give him or her bleeding. وانت ما تشعر به، والتاني ما يجيك لانه بيكون يتلحس. انت ما بتعرف your own statistics. لكن rest assured, if you take somebody with high bleeding risk to the cath lab ويو continued adapt ده وما وقفته، ما ركزت عليه انه يوقفه بعد 3 شهور ولا 6 شهور، rest assured انه you will cause bleeding to this patient. طيب نمشي للكرايتيريا. هي الكرايتيريا موضحة هنا، اوريك لها بطريقة ثانية. this ARC العالم كله موافق عليه، ولو قلت لزول ARC جريد كده تاني ما بيتكلم معاك اصله. ما يعني زمان كان في has bled وفي precise DAPT وفي the International Society of Thrombosis and Hemostasis Bleeding، ده كله اتلغى. العالم كله بيتكلم one language اللي هي الاي ار سي، اسمه البليدنج اي ار سي، اللي هو very validated, tried it, with the best available measure for bleeding. طيب اللي هم major criteria و minor criteria. If they are using oral anticoagulation therapy, major criteria هذه مكتوبة قدامكم، you can take a screenshot of it أو تمشي تقراها الهاي bleeding risk. If you have one major or two minor, انت high bleeding risk patient. Very simple. You think you won't meet these people, look at the frequency of these people. CKD 19% من الناس لقوهم CKD. Age more than 75, 60% of our population احنا بنخد فيهم stent are more than. Moderate CKD 50%. Moderate anemia 38%. So it can easily get one major or two minor. If you apply this in your daily routine practice to find out high bleeder, you will find 1 in 2 in each patient you're taking to cath lab, he will be or she will be a high bleeding risk. جرب ده في البراكتس بتاعك، بس ارجع للكرايتيريا دي تحفظها وتشوفها منو اللي انت شفته وما لاحظت للحكايات دي وديته كاس لاب وقلت له بلافكس واسبرين ديل ما يجيفوا اصلا. We were making big mistakes by doing that. لانه bleeding risk is real. وهو يا تو bleeding، شوف البليدنج اللي بيتكلم لك عنه ده البليدنج اي ار سي. bleeding ARC قالوا هم الكلام اللي قلنا ده بيمنع تايب 3 وتايب 5. ده العالم كله متفق على تقسيم البليدنج تاني. هسه تاني from now on whenever you speak about bleeding you have to تقول دي تايب 3 ده A و B و C. شوفوا قدر شنو ده. تايب 3 ده intracerebral hemorrhage. تايب 3 B hemoglobin drop more than 5 جرام. تايب A ده اخف واحد، اخف واحد انه اني ترانسفيوجن. لو قلت لها اديك بلاد ترانسفيوجن معناها البليدنج ده وقع فيه 3. تايب 5 ده it means death. ده زول مات بانترا سيريبرال بليد ببليدنج in an organ that caused death. pericardial effusion, pleural effusion, intraocular bleeding, intra اي joint bleeding. و to the extent يعني ده نوع البليدنج اللي بتلقاه في الكار اكسيدنتس او في الكاس لاب او في كده. كلاس 4 ده مع بدل كابج ريليتد بليدنج. عشان كده دايما بيقول لك 3 و5. اذا كان عرفت عيانك انه هو هاي بليدنج ريسك باي كرايتيريا، عنده تشانس انه يكون عنده بليدنج اي ار سي 3 or 5 risk more than 4% per year. يعني في كل سنة 4 من كل 100 من عيانينك لو خليتهم بيجيهم bleeding قدر الضربة زي ده. Therefore, it's very important first to speak the language, the same measurement we're talking. تنزل الاب واني عيان تشوفه من العياده قبل ما تقول لي داير قسطره، تشوفه هو هاي بليدنج ريسك ولا لا عشان تكتب. طيب انت some people ما يقول لي والله نحن الترايلز دي ما مقتنعين بها، نحن دايرين جايد لاينز. تورينا جايد لاينز خضراء بنحلف عليها بنشتغل بها. This is a guidelines. This is the latest ESCC guidelines for how to treat DAPT in ACS patient. دي الديفولت. ديفولت تديهم اسبرين، لازم اسبرين بعد ذاك معاه سترونجر برازوجريل او تيكاجرالور، ده كله اخضر. عرفت؟ بعد ذاك تستمر لمدة 12 months. ده immediately مع ال PCI default DAPT strategy 12 شهر. ده القانون كده. ده لا زول عنده هاي ثرومبيك ريسك، لا عنده هاي بليدنج ريسك. دير الناس اللي قال لك عندهم هاي بليدنج ريسك، دي الجايد لاينز. اول حاجه في الجايد لاينز دي انه الدي اسكليشن، الدي اسكليشن ده بيجيك له في السلايد الجايه اوريك شنو دي اسكليشن، لكن دي هنا الدي اسكليشن البعدة in high bleeding risk patient aspirin or B2Y12 receptor monotherapy after 1 month of DAPT. دي بقت 2B. In patients who are event-free after 3 to 6 months of using DAPT and who are not high ischemic risk, antiplatelet, let me move this are not a high ischemic risk, single antiplatelet. شفت بدوا الجايد لاين all this science is interfering, and I'm sure in the next edition of the guidelines هتتحول حاجات كتير أخضر من هنا. طيب قامت بقت كده قال لك if high breathing risk only after 1 month of DAPT حول لسنجل، والسنجل ده preferably B2Y12 inhibitor preferably. إذا كان high bleeding risk مجحجح شوية برضو بعد 3 months. عندك حد 6 months خلوا حكاية 12 months دي. عرفت يعني بقى عندك license you have to reduce the de-escalation. انت لو كنت بتستعمل stronger B2Y12 prasugrel or ticagrelor and you felt that this patient risk of bleeding is considerable, you can de-escalate clopidogrel بعد 3 months. ده اسمه الدي اسكليشن. لكن قال لك الدي اسكليشن في الفيرست مانث تختاو. الدي اسكليشن ده شفت الناس دي الحكايه الستنت ثرومبوزين in the first 30 days دي بنوا عليها a lot of science. Do not touch aspirin in the first, do not de-escalate in the first 3 months. After 1 month من دابت بعد ذاك عندك اليوي. طيب نشوف the next step, the topic I like most. Patient with AFib requiring. احنا الزمن كيف يا دسوم؟
باقي لنا 5 دقائق لصلاة المغرب هنا في الغويط.
Okay, I will try to finish with that time.
اوكي.
AFib, you have to give them anticoagulation. Aspirin or DAPT is not good enough for preventing of embolic consequences of atrial fibrillation. This has been tested and done. Stent thrombosis, oral anticoagulation is not good for preventing of stent thrombosis, being tested and buried. Head-to-head comparison between DAPT against oral anticoagulation failed since 1998. For stroke جربوا الدابت head to head مع الاورال anticoagulation. الدابت failed. So atrial fibrillation ووب و PCI ووبين لو جمعتهم مع بعض there is a lot of bleeding. In AFib و PCI وتديه الديل bleeding. دي تعمل كيف؟ وين الجايد لاينز؟ قاموا عملوا الترايلز دي. الفورال في النص دي بايونير PCI, read dual PCI, interest PCI, Augustus. These are the 4 trials that made our knowledge today about what to do with this. I will just touch in the, this is the meta-analysis of all these major trials. They proven that on this side, let me move this again. On this side, bleeding, this is favoring dual antithrombotic therapy. Everybody is getting on this عنده AFib وبيعمل له BCI لازم بيكون بياخد anticoagulation يا وورفرين يا نواك لازم. الحتة الثانية هل تضيف له اسبرين بلس تضيف له دابت عشان يبقى تريبل انتي ثرومبوتيك ثيرابي ولا تخليه دول انتي ثرومبوتيك ثيرابي؟ يعني الدول انتي ثرومبوتيك ثيرابي هو اورال انتي كواجوليشن معاه سايوبريدين ومعاه اسبرين، ده التريبل انتي ثرومبوتيك ثيرابي. وهنا فيفرنج الدول انتي ثرومبوتيك ثيرابي. طبعا لوجيكالي يقول كل البليدنج is better لما يكون الدول انتي ثرومبوتيك ثيرابي، لكن اللي يقول stent thrombosis ده is significantly better لما تستعمل التريبل انتي ثرومبوتيك ثيرابي. بقى لو استعملت التريبل انتي ثرومبوتيك ثيرابي عشان تمنع الستنت ثرومبوزيس ده هتخش في البليدنج ده. عملوها كيف؟ قاموا رجعوا للترايل دي وفرتقوها وحدي وحدي، لقوا انه تستعمل تريبل ثيرابي فور 1 week 1 week of triple antithrombotic therapy. بعد 1 week تقلب دول antithrombotic therapy لانه الداتا كده لقوا الناس اللي في اغسطس دي اكبر وحدي انه الستنت ثرومبوزيس 0.04 لانه الميديان تايم اوف التريبل كان 1 ويك. في ديل 1 مانث ما في ستنت ثرومبوزيس. فيبقى الجايد لاينز بيست اون ذس انه الستنت ثرومبوزيس is significantly one better لما تستعمل 3 مع بعض for 1 week. دي الترايل بتاعت الاغسطس عشان الزمن حيمشي فيها سريع. اي زول منهم بياخد كولوبيدوجريل، العشر الباقيين ديل بياخدوا كانوا برازوجريل. يعني الفرشه انه بتاخد كولوبيدوجريل. مع الكولوبيدوجريل ده يدوك ابيكسيبان ولا يدوك وورفرين؟ يعني جربوا وورفرين اجينست ابيكسيبان، بيقول ابيكسيبان ماتش بيتر. طيب انت بتاخد كولوبيدوجريل وبتاخد معاه ابيكسيبان، نديك اسبرين ولا ما نديك اسبرين؟ يعني ده بقى الثلاثه اسبرين بلس ابيكسيبان بلس كولوبيدوجريل اجينست كولوبيدوجريل بلس ابيكسيبان وما في اسبرين. دي الناس كلهم عندهم اتريال فيبريليشن وعملوا لهم خدوا لهم ستنت. الناس اللي لقوا في البتاع الحته دي بالذات انه عملوا له ستنت ادوا كولوبيدوجريل وابيكسيبان وما ادوا اسبرين، فطوا من جوه التيت لقوا عندهم significant stent thrombosis. الناس اللي لقوا انهم ادوهم اسبرين بعد الاسبرين شغال بعد اسبوع وقفوه ما جاتهم stent thrombosis. عشان كده the 1 week in the guidelines coming from this arm. فهمتوا الترايل دي كيف؟ يعني في الاول كل الفرشه انه بياخدوا كولوبيدوجريل، غارنوا ابيكسيبان اجينس وورفرين وطلعوا الورفرين ده برا، الا زول يكون عنده مايترال فالف بروستيسيس وده السبب الوحيد، او ولا مودريت مايترال ستينوز. الترند ابيكسيبان معاه اسبرين لمده اسبوع، تخت الاسبرين ده لمده اسبوع بيجيك ستنت ثرومبوز. قاموا دخلوها في الجايد لاين، لقوا في الترايل دي اني تايم تستعمل اسبرين ده بليدنج، فيتامين كي بلس اسبرين، ابيكسيبان with aspirin دي البليدنج is high. احسن حاجه لقوه ابيكسبان بلس بلاسيبو 200، لكن بعد تستعمل اسبرين لمده 1 ويك. يعني الاسبرين ده بصراحه لقوه during الفيرست 30 days بينقص الستنت ثرومبوزيس. بعد 30 days ما بيعمل للستنت ثرومبوزيس اي حاجه، لكن بيزيد البليدنج بعد 30 days، وبيزيد البليدنج قبل 30 days، لكن فايدته قبل 30 days بينقص الستنت ثرومبوزيس. عشان كده حافظوا عليه. احسن وقت لقوا انك تستعمله لمده 1 ويك، عشان كده الجايد لاينز جات كده. قال لك باي ديفولت استراتيجي for patient with atrial fibrillation وتشاد فا 1 or more، وانت تقدر تاخد له ستنت after up to 1 week of triple antithrombotic therapy the ACS event or stent NOAC at recommended dose. يعني ده اخضر، ده ما في اي كلام، ما بتناقشنا فيه، بس تعمل اللي بنقوله لك قالوا لك. زول عنده اتريال فيبريليشن بياخد نواك، وديته كاس لاب تديه 1 ويك اوف تريبل ثيرابي، بس تغمض وتصلي وتديه. افتر 1 ويك تريبل ثيرابي تستحمل البليدنج اللي بيجي ده وتديه. دي الجايد لاينز كده، وقاموا خدتوها بالطريقه دي. دي الديفولت استراتيجي تريبل انتي ثرومباتيك ثيرابي. وكل الترايل قلت عليك دي كولوبيدو جريل اسبرين ونواك. الزول ده بعد 1 ويك تمشي تديه دول انتي ثرومباتيك ثيرابي، توقف الاسبرين تستمر بالنواك والكولوبيدو جريل. بعد 6 شهور تراجع الموضوع ده، زولك ده هاي بليدنج ريسك. شوف ده انت هاي بليدنج ريسك تراجعهم بعد 6 شهور، ما في زول بيزالك. اذا كان هاي بليدنج ريسك توقف الكولوبيدي جروب تكون زول نواك، بس ما هاي بليدنج ريسك تستمر كده. اما الناس اللي عندهم هاي ثرومبوتيك ريسك زي الناس اللي قلناهم ديل 60 ملم اوف ستنت بايفوركيشن كالسيوم موديفيكيشن ليفت مين، ديل لانه بتخاف تستعمل التريبل انتي ثرومبوتيك ثيرابي لمده شهر ده غايته الا بس تسافر تخلي البلد، الزول ده تديه الشهر ده تقول ليه انا ماشي لمده شهر. استعمل اسبرين ونواك ومعاه كلوبيدو جريل حتى بعد ذاك تتفاهم معاه. دي جايد لاينز دي مبنيه على الاغسطس ترايل. ال6 مانثs دي بعد 6 مانثs انه تستعمل نواك مونوثيرابي، يعني تستعمل ريفركسوبان 15 مللي جرام، دي جايبينها من الماستر دابت ترايل كلها خشه. وهنا بعد 12 مانثs تستعمل نواك، دي برضه في ترايل عملت كده. بعد ما الناس دي قال لهم جيبوا لنا بعد سنه، ودوهم نواك مونوثيرابي، وزول عنده دعامه وعنده اتريال فيبريليشن وما جاتهم اي عوجه. عشان كده لو زولك ما هاي بليدنج ريسك بعد سنه تستمر في النواك مونوثيرابي وهو عنده دعامه. ما تقول داير يستعمل له اسبرين عشان عنده دعامه وما ما بيمشوا مع بعض اصلا. الاسبرين والنواك لونج تيرم ما بيمشوا. لونج تيرم نواك اونلي، زول عنده افيب ودعامه نواك اونلي after 12 months. even after 6 months نواك اونلي. ديل الهاي ثرومبوتيك ريسك ديل لمده السنه دي بعد الشهر 11 شهر تستعمل النواك والسنجل الكلوبيدو جريل. في التريبل ثيرابي ده اصلا ما في برازوجريل وتيكاجرولور، اس اونلي كولوبيدو جريل في التريبل ثيرابي. انا بفتكر ده الفيوتشر حيكون كده. الفيوتشر هو الدرج اليوتنج بالون تريحنا من الدعامات دي وكده. فارجو الفيوتشر ده حد ما اجي اقول قولي هذا واستغفر الله لي ولكم، و Thank you so much for listening. I hope I got my message across. You have to define the bleeding risk of your patient ahead of time. Use الاب bleeding ARC. شوفوا الاب واحسب لاي عيان البليدنج ريسك عشان تقول له بقلب قوي توقف الدبت بعد 3 شهور عشان ما تغطس حجره ببليدنج. هو لا ايده لا كراعه، وكل صيغته فيك انت انك بتديه الادويه السليمه. والعلم ده كله اجتهدوا فيه وخدتوا لك الترايلز دي beyond any reasonable doubt. So you have to utilize it. You have to tell your patient stop after 3 months. شكرا. لو في أي سؤال.
Thank you very much, our great teacher, Dr. Awad Abdalla, for this very wonderful. Actually, this is one of the talks that you don't find it routinely. Thank you very much. And because our time is very short, لو سمحتوا لي يعني أدي فرصة لأستاذنا العظيم دكتور عبد الرحمن زيادة، وبعده أستاذتنا دكتورة صفاء حسن الطيب. Please welcome دكتور عبد الرحمن زيادة أستاذنا. welcome.
Please.
عبد الرحمن.
Please unmute yourself دكتور عبد الرحمن. أستاذنا دكتور عبد الرحمن. يبدو عنده مشكلة دكتور عبد الرحمن في دكتورة صفاء. do you hear me؟
السلام عليكم.
عليكم السلام دكتورة صفاء، تفضلي.
يا أستاذنا الكبير أو صديقنا الكبير أو you name it. عبد الله, it's so nice to see you عبر الأثير.
الله
بعدين
يبارك فيك.
نفتكر you have a very pleasant way as usual of putting the information on stressing the facts. يعني a wonderful lecture في what I think is a very challenging topic. Awad, but I want you to comment on 2 issues that you've raised in categorizing the high bleeding risk. وأفتكر we have to put it in bold letters لأنه these are everyday. في مرات أنا التحفظ بتاعي على الويردنجز بتاعت الأشياء ممكن تكون مخطوطة فيج وفي النص فيها اذهب أنت وربك فقاتلها. يعني لما تقول low platelet count الحكاية دي مفتوحة. Abdullah, I want you to define for everybody listening to you how low is low that should make you really step back, and how many steps you have to take back. يعني اللو الممكن you transfuse platelets ولا اللو الممكن in putting in mind this might be a very emergency situation that you have to go in في عيان platelet count بتاعه 35,000 versus those whose platelet count is 15,000 versus those whose platelet count is 50,000. الجماعة اللي ما بيستووا. We need a better definition of this.
بس الأخيرة اللي قلتيها دي 50. Anything below 50 يا صفاء you're in a very dodgy territories. يعني 15 و 35 دي definitely the patient is going to get into trouble. لكن هو arbitrarily defined less than 50 is a very dodgy. I
طيب لكن
understand.
الحياة ما always that colorful يا عوض. There's so
ما
many
عشان
patients
كده
out there.
ما عشان كده هم
What do you
قالوا
what do you advise people to do for which number? خلاص they calculated the risk, the bleeding risk is high, وده situation قدامك والعيان عيان صغير 35 years 40 years into some sort of diseases that is going to jeopardize his platelet count. It will never be optimal. الناس تعمل شنو؟
انت هسه if you look at the app and I tried to open the app and put platelet 50, it would definitely low platelet will be one major, And look at the number of patients who had low platelet, very little number. يعني انت اخترتي اصغر واحدة اللي هي في population 3% of of all comers, they came with a problem of low platelet, which I agree with you. It's not straightforward, to be honest. يعني 50 55 ده انا اقول له استعمل for 1 year الجري زون ده. ففعلا it needs more than one. It's easier when there are two minors, I can understand. Or it's a very strong major like the oral anticoagulants. Somebody عنده AFib وبيستعمل نواك ده straight forward. This is high risk patient. لكن I couldn't agree more with you in when it comes to low platelet, the bone is white, open. لكن 15 مثلا I can understand. لكن when it comes to grade on around 40 to 50, it's a dilemma, to be honest with you. Unless there is another factor that will reassure you to whichever way this patient is going to be falling.
Definitely.
سؤال جميل.
On the same
وثقيل
level, one last
وثقيل
question يا
وثقيل
أخي.
برضه. ثقيل دي
one
سمعتي.
last سمعتها طبعا. typical عبد الله زوير أو عبد الله زويردين. هديك بس سؤال تاني لأنه شايفة دكتور عبد الرحمن زيادة is getting on the line. بنفس المستوى يا دكتور عوض. those with intracranial bleed يعني من ما خلقوا ال thrombolytic therapy absolute contraindication بعد ذاك things were softening out لأنه ما كل ال intracranial bleed are the same. لما أنت تتكلم عن an intracranial bleed 10 years ago versus an intracranial bleed 6 months ago versus intracranial bleed 80 months ago. دي نمرة واحد. نمرة اتنين, is it an extradural, is it subdural, is it intra ventricular. افتكر هم ما كلهم the same. فهل عندك elaboration more على الحكاية دي؟ دي بالنسبة لنا مهمة. افتكر دي population شوية كتيرة elderlies اللي بقعوا عندهم collection and it gets evacuated ويجوك بعدها بشهرين ثلاثة infarct and you have to go in. دي افتكر جروب اكبر شوية من الثرومبوسايت.
ايوه هو any intracranial hemorrhage اذا كان الريسك بتاع البيشنت more than 1% in هم they calculated, they found the events and they went back to calculate the major or minor. Say for the major criteria, a major criteria is defined as an event that on its own, if it gives you a risk of bleeding ARC 3 to 5 more than 4% in a year, the major criteria. And minor criteria, if on its own can give you bleeding ARC less than 4% in a year, دي سموها minor. الانتراكرانيال hemorrhage ده خدتوه as the category براو. If you are defined as a high bleeding risk معناها انت عندك risk of bleeding in the brain anywhere, intracerebral, intracranial, subdural hematoma, subarachnoid hemorrhage, more than 1%. You're going to get one of them, more than 1% a year. وإن fact هو خدتوها at the same criteria الانتراكرانيال hemorrhage مع الانتراocular hemorrhage مع الانترابريكارديال بيجينا مع when you perforate the coronary artery. Any bleeding in any organ that can lead to this amount of bleeding is considered one. So a differentiation between where the bleeding is in the brain is very subtle.
I think this is very, very wonderful. I would like to remind our colleague who are outside the cardiology community, this now we are listening to the king of the hero of intervention cardiology.
لا كينج عبد الرحمن قاعد وبعدين الكوين صفا قاعدة.
In the country talking to the queen of imaging in the country. This is very, 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 very a great moment actually that we needed in our meeting. Thank you very much أستاذنا دكتور عواد عبد الله. Thank you very much أستاذنا دكتورة صفاء. Thank you very much أستاذنا دكتور عبد الرحمن زيادة. And thank you
Can
to...
I just make can I just make a small comment? I won't take long before you finalize.
تفضل دكتور عبد الله تفضل.
This talk is even beyond state of the art.
Thank you.
It was a lovely journey, taking the past, putting the accumulating evidence of what we should do, not what we do. And I think it has been put in a most fantastic way. This was great, fabulous, and fantastic. Most expressively out.
Thank you.
Congratulations for putting things like this. It is very clear now. What is needed in Sudan is that all this is put together in some sort of guidance so that we are not astray, everyone doing things in a non-standardized way. Like I'm very pleased for the lovely talk, the elaborate talk, the great construction of the talk, full of thought and full of evidence. Thank you very, very much, Awad.
Thank you عبد الرحمن الله يخليك من فضلك.
Thank you very much أستاذنا الدكتور عوض. نحن عاوزينك توعدنا إن شاء الله في الغريب العاجل maybe 1 month 6 weeks for another interesting talk إن شاء الله نرتبه
إن
معاك
شاء الله.
إن شاء الله. شكرا لكم كلكم وكتر خيركم. السلام عليكم ورحمة الله.
عليكم السلام.
Thank you very much.
تحياتنا للبلد. الله
إن شاء
يبارك.
الله. Thank you very much.
شكرا جزيلا.